Welcome to the Drip Podcast. Today's guest is a clinical nurse specialist working as a medical science liaison at Baxter. She received her undergraduate nursing degree from Olivet Nazarene University and an advanced practice graduate degree from Governor State University. She is on the Sepsis Alliance Advisory Committee as well as holding numerous professional memberships at ACN, SCCM, INS, and NACNS. In 2023, she published an article in the Advanced Critical Care Winter Edition titled Advanced Variables to Optimize Hemodynamic Monitoring. Please welcome Angela Craig.
Welcome to the Drip Podcast. This is our first episode. I'm your co-host, Clayton Grigsby. And if you heard that wonderful woohoo in the background, that's my wonderful host of the podcast. That is Angela Craig. Angela, take it away.
Hey,
what do we want to say today?
Everyone, it's so good to have you with us. We are excited to talk today about a lot of things sepsis, right?
Sepsis, yeah.
Yeah, it's big, it's bad, it's ugly. But there's a lot we can do to really help this patient population. So I'm excited to get this topic kicked off.
Yeah. So honestly, if you're sitting out there, you're a sepsis coordinator, you're a nurse, you're a doctor. If you have your hands on sepsis in your hospital, this episode is for you.
Absolutely.
It's going to really let us know kind of what's coming and what to expect and how to kind of sharpen your skills up on sepsis. So let's just get right into these questions here. So some of the questions I have written down here is, what made you, Angela? You're such a big personality in the sepsis world. What got you into that?
Well, Clayton, honestly, I realized that we had a big gap. And I'm also a clinical nurse specialist, so an advanced practice nurse. I chaired my hospital sepsis team for many years. And I knew that we had a gap in care for this patient population. And we had a high mortality. This was back pre-CMS days, right? So we didn't have people who extrapolated all of our data and who were able to give us numbers. We had to do that all ourselves. So we had some nurses who were passionate about it, and they helped, and we would start gathering data. And we realized that we had a mortality rate that was way too high, right? Even if it was a small subset of patients, I think our first subset was maybe 30 patients that we looked at that were septic shock. We realized and we recognized that this mortality just was way too high. The other thing I realized is that guidelines were out and I was not on top of my guideline game, right? I'm kind of a nerd. Okay, I'll break it to you. I do I do like guidelines because I think it shows us the science and the evidence and the why. I'm a big why girl. Don't just tell me what to do, but explain the why behind it. So, I started digging into the guidelines and I realized we had great opportunity to better care for this patient population. And
I
go ahead.
love that. Yeah, no, I love that. I think you're singing a common tune that we see across hospitals.
Yeah, and I think it's important if I can focus on one thing. I think as practitioners, we have got to know what the guidelines are and what is considered best practice so that we can make sure we're really focusing on the right thing, right?
Sure.
Now,
Yeah. So I
go
go ahead.
ahead.
No, I was just going to try to shape that into another question. So you kind of talked about, getting your feet wet a little bit in the sepsis world, kind of what kind of helped drive you early on. What makes you most proud when it comes to the work you've done with sepsis? What do you like to see?
Yeah, I really like to see. I felt like it was a win-win regardless because the studies and the evidence showed at that time and still does that if you do the right thing, you're going to decrease mortality, you're going to decrease hospital costs, and you should be able to decrease length of stay. So for the hospital standpoint, that's a win-win, right? You're going to save money, hopefully. But for us, it was really that drop in mortality. And that is what we saw initially. Now, I will tell you this, it took a lot of work to build this program. And I thought it would be fun to kind of briefly just share with you kind of how
Please.
what our
Yeah, please.
base work was in developing this. I think most people probably have developed, or maybe not though. Maybe this is your year to really start working and developing your sepsis program. So we utilized a model that some of my friends and colleagues had developed. Many of you have probably heard of Kathleen Volman and Pat Posa,
Oh,
but
yes.
it was like a
Big names.
triangle. Yeah,
Yeah.
big names that in the sepsis world that have done so much. So grateful for their help and their mentorship in this area. And they had this triangle. It was almost like the Maslow's hierarchy of needs, right? Where you have to get that base before you can move up that triangle. And there are 4 steps. So I thought I would briefly just mention them on what you need to have to be successful with a sepsis program. And the very first one is interesting because it says organizational consensus that severe sepsis must be managed early and aggressively. So what that means is that it cannot just be us on the floors wanting to do this, right? We have to
Right.
have
Right.
support from the C-suite level. And I think right now sepsis has the attention of the C-suite for sure. Don't you think? I don't think I'm making that up.
I No, I don't think so at all. I think that's definitely a reality. It has to happen.
Yeah, it does. And right now, as we move toward pay for performance, I just think it's got the attention of everyone. So, as long as your C suite, your administration is on board, the next is early screening with tools and triggers. We've got to screen our patients. We have to have tools and triggers. We need to give our nurses and our providers the tools they need to be able to handle this patient population well. And then the next one is implementation of the sepsis bundle, which that's a lot of work as well. Getting your order sets ready, getting your screenings embedded into your EMRs, making sure you have your alert systems working, making sure everybody's on the same page, all the education. It's a lot. And then we do all of that. And then our final is measuring success. And sometimes I think that you think you've gotten to that top lever and you're like, yay, we've made it. And then we find out that actually that's one of the hardest things, right? The
Yeah.
hospital I worked with, and I still work with actually, we were the first hospital in the state of Tennessee to become sepsis disease specific certified. And wow, that was so awesome when we first became certified in 2015. We realized that, oh my goodness, measuring the success, that's the hard stuff, right? Keeping the momentum, right? That's where it's hard. So that's just a little bit about how we initially started that. And I hope that's helpful for someone.
I think that measuring success is one of my favorites because it is a big lift to do all this. So it's kind of nice to see what is our big lift, what is that gaining us, and what does that look like for our patients. So I think the measuring success is, there's a saying out there: we only manage what we can measure. So
And I love
I,
that.
I think. I think if we can have that data, I think it helps us along the way for sure. So let me paint a picture real quick for you, Angela.
Sure.
I'm a brand new novice sepsis coordinator. I have no idea what I'm doing. Where do I even start?
Yeah, that's a hard one if you're brand new to. I recently met someone who is brand new to a very large institution. So, brand new to the institution and brand new to being a sepsis coordinator. So, kind of a double whammy. And, one of the things we try to do as medical science liaisons is really help hospitals and partner with them, right, regarding the sepsis initiative as well as with, fluid management initiatives. And so I think the number one thing is to network. And I know that we can help hospitals network because we've got some connections, but the Sepsis Alliance, that's out there. There is a chat option there where you can ask any question. You can network with so many people across the country. It is amazing. So I highly recommend Sepsis Alliance. I know I don't want to badger the guideline point, but you've got to know your stuff. And I realized early on I didn't know my stuff. And so I as I learned, then I'm like, wow, we have to be able to speak to providers. We have to be able to give intelligent information to them, right?
So important,
It
so important.
it really is, Clayton, and I think if we don't know it, they're gonna know we don't know it, but most importantly, I like to always bring this back to the patient, right? It's most important that our patients get what they need, get the care they need so that we have better outcomes. So once again, I say network with other area other area clinical nurse specialists, as well as other area sepsis coordinators. But another thing I want to share with you is we have a Tennessee Hospital Association, and I believe most states have hospital associations. I And I will tell you that I put a lot of pressure on the Tennessee Hospital Association. I kept saying, we need a sepsis collaborative. We need a sepsis collaborative. We need a sepsis collaborative. And you know what they did? They have a sepsis collaborative now. And that is one of
Wow.
their priorities. And I'm not saying it was because of me, but I think the combination of people who did need help with that population. So we meet monthly. It is wonderful. Across the state, people get on, we meet virtually, and then 4 times a year, we try to meet in person. And it has been invaluable. We share data, we share information, we share templates, we share. And I think just know this, that people out there are willing, some people, most, I think a lot that I've worked with are willing to share. We don't want you to have to struggle. We've been there and done that, and we want to help. So be able to network, ask questions, ask for things. We're willing, if we can share, we will. If we can't, we won't. But I think many of us are really happy to share.
I think that's so awesome. Especially I can't agree more with the networking and hospital associations. It's not too hard to get online and kind of see what your community looks like and solve common pitfalls, right?
Absolutely.
Uh,
Absolutely.
so let's go to the SEP1 bundle. In your opinion, when we're doing the SEP1 bundle, there's a lot of usual suspects out there, right? So what do you think is the hardest part of the SEP1 bundle?
Yeah, so I think the hardest part of the Step One bundle probably would be fluid management for sure. Now, what I'm
I
going to
agree.
say is,
Yeah,
yeah, I think it's the hardest, but I will say that time to antibiotics can be a challenge. So if that is a challenge for your institution, I highly recommend that you get a subgroup together and you really look at specifically, and you look at the delays. What is causing a delay? Is it that the product isn't available in your area, or is it the antibiotics not available? What is it that's causing a delay? But I think, I know at my institution, we've kind of figured that out. We're able to usually give that antibiotic within an hour. I feel like we're really good with getting blood cultures and getting lactic acids. We've got a nurse-driven protocol. If you don't have a nurse-driven protocol, I highly recommend, if a patient comes in and presents and meets the criteria, those are just things you're going to need to get. Now, let's talk about fluid management for sure. Fluid management is the challenge, right, Clayton?
right,
And
right. I agree. Yeah.
I can hear the question in your voice. How can we get this better, right?
Yes.
Uh,
Yeah, absolutely.
my answer to that would be, I am a big avid component to stroke volume guided fluid management.
We share that. Yeah, definitely. So I think stroke volume guided care is right now, I think it's the best chance we have for patient outcomes, especially when we're looking at fluid management. So
Absolutely.
not looking at that blood pressure anymore. We need something a little bit more flow guided, more something that's looking at more hypoperfusion, during the sepsis state. So I think stroke volume
Absolutely.
is a great needle to look at when we're looking at fluid management. Yeah,
Absolutely. Absolutely. And then when we think about, data to support that, because I don't just want to be one of those people that says, do this, but don't give you the why, right, behind it. And what
that's
have
right.
we seen? Well, one of the things I think that's very interesting is in a Benser study, it showed that 50% of our hemodynamically unstable patients, only 50% are fluid responsive. What does that mean? That means that only 50% of our patients may really benefit from fluid, right? So
Right.
let's go back a little further and let's talk about a few other studies, or move forward. A few other studies, the UK study. And basically, the UK study looked at patients with a regular fluid management population versus a stroke volume guided fluid management population. And what they found were better outcomes, right? And you probably could read those off to me, the percentages. Um,
I might have them memorized. Yeah.
yeah, share with us what
And
those were.
yeah, so I think that's what you're trying to say is the KU study, not the UK study, but that
Oh,
was done
shoot.
by. That's
I
okay.
I'm so
That's
sorry.
So that was a study done by Dr. Latham and team at the University of Kansas, and you're exactly right. They put patients into two categories: a usual care versus a stroke volume guided fluid resuscitation treatment arm. So what they were able to achieve by using stroke volume versus the usual care model was they're able to reduce mechanical ventilation risk by 50%. They're able to reduce CRT initiation by 2/3. They're able to drop the use by hour of pressors by almost 50%, which was pretty amazing. And then also another finding that they had was they're able to get the patient out 3 days earlier. So if we were trying to quell our fluid management, our fluid overload, there was no reason to diuresis patients they could get out of the ICU faster. So that's something that was amazing. And then just to kind of push that across to more recent studies, we had the FRESH trial, which is the first RCT is showing outcomes with patients in sepsis. So that was amazing as well. So they kind of borrowed the KU model. They had usual care versus stroke volume guided fluid resuscitation. What they also found in that study was a 50% less mechanical ventilation risk, which mirrored the KU study. Wasn't statistically significant, but it was definitely clinically significant, was a 3-day reduction in ICU stay. Another thing they found was 2/3 less CRT as well. And one great finding that I really liked out of this that really shows the impact of the patient was 20% more patients were going home alive instead of going to a SNF, or what we call a skilled nursing facility, or into like a palliative care situation. So I think great outcomes. And what
Absolutely.
isn't everyone doing this, right? So
Right. And I think it's important for us. Thanks for summarizing that. And I think it's important for us to realize that, this stroke volume guided care can be done totally non-invasively. So
right.
I think sometimes people think you need to have invasive lines and you don't anymore. So we can do this non-invasively. We can even do this in the emergency department to really get fluids right. And so I just want to encourage people to kind of think outside the box, right?
Right. So we kind of talked about getting our feet wet. We talked about, maybe fluid management and some common pitfalls that we could probably pay a little closer attention to. So let's kind of talk about what the behavior of the federal government is going to be here. So the
Yeah.
big question now is the pay for performance. What is that going to look like? Is it affecting us now? And what is that going to look like for the future for hospitals?
Yeah, yeah, this is important. So, pay for performance means we are all going to be held accountable for how well we are doing with our sepsis patients. They have added this into the safety section. And baseline period was 2022. So, I don't know how well everyone did in 2022, but they are also giving us an opportunity in 2024 to bring that number up. And then you can use whatever is better of the two. So we have a big job to do, right? It's February of 2024. We need to get those numbers up, and not just for what it's going to do to the hospital as far as financially, but for our patients, right? I always try to bring it back to the patient, right? We want to do the right thing for the patient. Now, I think what you want to do is really try to evaluate where you're falling out. So I know at my hospital, they are able to kind of bring it down to how many fallouts do we have with the lactates, how many fallouts do we have the blood cultures with the fluid, et cetera. So we're able to really focus on that. And then there's also been some programs that have come out. The CDC recently put out a gap analysis to help you evaluate your program, and it's a robust evaluation, and it's really excellent. And actually, we're going to be helping to do some of these gap analysis out in the field. And that's one of the things, just to throw a little pitch for our role. We are medical science liaisons with medical affairs, but we are in the field as well. So we are customer facing. And I love that part of our job, where we're not just always in the office, but we're public facing so that we can kind of work with you and with your hospital. And one of the
I love that
Yeah.
tool. the sepsis gap analysis. Honestly, if you're someone that is sitting in your hospital and you just really have no direction, I think the sepsis gap analysis is a great start to show where your pitfalls are, where we can kind of, you know, fill those holes,
Mhm.
and we can get better patient care on the horizon, right?
Absolutely. And what it does, Clayton, is it looks at 7 areas. And this is a high level gap. So you definitely want your C-suite involved in this, but it looks at hospital leadership commitment. It looks at accountability. It looks at multi-professional expertise. It looks at action. It looks at reporting, it looks at education, and it looks at tracking. So it's a very robust gap analysis. I can definitely, we're always happy to send this to you, but it's actually out there on the CDC website. But we're also happy to network with you as a hospital and just work with our customers and help them better this patient population of sepsis.
I love it. So let's kind of wrap this up. I think we really gave people a lot of options to discover here for bettering their sepsis program. Let's get
Absolutely.
into some fun. Let's get into some fun questions. I want some fun questions for my friend Angela here, right? So
Okay, go ahead. Hit me up.
uh, let's talk about your nursing career and what is some of your best memories.
You know, there are so many memories, and I think as we think about feedback that we get, I remember one day I had a patient who colored me a picture. And they were just happy that I had spent some time with them. And they colored a picture for me. I remember putting that with a note, and I put that on the back of my door just to remind me to keep focused on the patient, right? Probably one of my most favorite memories in the hospital was during the COVID time. Okay, let me back up and say COVID was not a happy memory, right? We were in the ICU. It was tough, but we realized that our patients really needed more support. And my son, he's in med school, and he was a patient care associate. And I said, "Hey, Zach," his name's Zach. Can you bring your guitar to the hospital? And he's like, "Well, yeah." And I remember going from room to room for the patients who needed a little more encouragement, support. We weren't allowing a lot of visitors. So these poor patients,
Right.
back in the day, I mean, we've come a long way now. We've learned a lot about COVID, but I realized they needed more. So anyway, my son would play the guitar. We would sing outside of the room, and the patients, some of them would cry, some of them would just be so happy. We would do some fun songs, or we would do serious songs based on what genre of music they liked or what they wanted. But it was just one of the sweetest memories I have, probably because it was my son too, but also what it did for the patients. And what I think is kind of a funny note, the secretary said, "Angela, it was like in the Titanic when they're playing that music and the boat is going down, but yet you hear this awesome music." She said, "That's what we felt like the Titanic was going down, but yet we had music." But anyway, what I wanted to say about that, not just to focus on that, but we went a step further. And so we reached out to the foundation and we said, "Listen, well, first of all, I reached out to administration and I said, we need music for these patients. If they need, whether they have their own, whatever they have, of course, what can we have in the room to where they can have whatever genre of music they wanted?" And administration listened to us, and they ended up getting a system where now there's all kinds of genres of music for them that they can listen to. But also the foundation bought us a piano and bought us a cart on wheels, and we can go room to room. And the hospital also paid for the foundation also paid for a guitar. So that's there in the ICU. And I was just in there the other day, and one of my family members was in the hospital. So I grabbed the piano and went in there, and it happens to be she was a relative that absolutely loves music. So we went in there, and I saw the nurses came through, and some of the nurses jumped in and started singing with me. And then one of the people who can play the piano, I called him down, and he played a beautiful song. And I was talking to my husband about this. I said, not only was that really speaking to the patient, but I looked at what that did to the nursing staff, right? How we find meaning by having meaningful things happen with our patients. So that's kind of off topic of sepsis, but it's just one of those things that I find near and dear to my heart. What can we do to make our patients have better outcomes? And if it's not going to be a better outcome, what can we do to help them just to feel better about themselves in the situation they're in?
Wow, what strong words to leave this podcast with. Angela, Craig, I always love the joy you bring, and that I know that joy gets expressed across to your patients. And that will wrap us. Oh, thank you for being here, and thank you for being the host. And I think we have a fun journey to go here. And I tell you what, I can't wait till the next one. So
I know, I can't either.
We'll wrap this one up, and we will see you next episode.
Absolutely. Have a good one.
As we conclude today's episode, I remind our esteemed medical colleagues that the opinions expressed herein are solely intended for professional discussion and should not be construed as medical advice. We encourage all listeners to consult their own healthcare providers for personalized medical guidance.